In the next 15-20 minutes, I talk about the adjuvant treatment for non-small cell lung cancer, and I hope that I give you the answer of this question: is adjuvant treatment in non-small lung cancer close to cure, or we just delay the progression? We're talking about the transforming cancer care. We know about the new understanding of cancer. So it's pretty clear, and all you know, that the overall survival depends on the stage of the disease. So it's better in the early stage and less in the fourth stage. But if you see the number of the percentage of the patient alive in the 5 years after the diagnosis, the percentage is 78-88. So this is not 100%. It means that we should add something after the surgery, because the standard treatment of cancer is surgical treatment. Yesterday evening we discussed with Professor Manegold what is the main role of the surgery, and is this approach is so important like years ago. So I show new data and what we should do and why we use this adjuvant treatment in this setting. So years ago, this has happened before more than 10 years, we add after the surgery chemotherapy, because this was our weapons against the cancer. But you see that this improves overall survival 5%, so this is not close to the 100. But even this was the breakthrough and very, very important news that we can use adjuvant treatment in lung cancer. So this is not breast cancer, this is different kind of cancer. And nowadays it's not easy to manage patient with 3 stages of lung cancer. Maybe it's easy in the first and the second, because the surgery always upfront in this stage, but it's very provocative and very, very challenging to treat it and to cure patient in this stage. So nowadays we have all this possibility to choose in which way we give the right treatment to the patient. For stage 3A, we have neoadjuvant aspect and prospect for this patient, combined chemo and immunotherapy. This is the strategy confirmed by clinical trials, so this is possible, and this is improved the overall survival in the patient. After this, we decide to operate patients, so surgical approach in the middle, and after this, we decide to give this patient adjuvant treatment. In a very specific group of patient of non-small lung cancer is the patient with mutation. So for this patient in 3A stage, we recommend first to start with the treatment, the surgery, and after this give the adjuvant treatment, chemotherapy and target therapy. And the patient without mutation, we can choose immunotherapy. For the stage 3B and 3C, it's a little bit different situation. So usually we here is one small part of this patient is not suitable for surgery for many reasons, so we should decide for them combination of chemoradiation, and after this continue with immunotherapy. All this approach is for patient without metastasis. So we really want to transform cancer care and to say that the patient with early stage 1 cancer, we can treat it and cure them. And for 3C, we have only this possibility, concurrent radiation, chemotherapy, and continue with immunotherapy if the patient with PDL expression more than 1%. So it's not necessary to looking so far away in the years. In the last 5 years, the things change very much. So we have proven adjuvant EGFR TKI inhibitors for the patient, lung cancer with EGFR mutation. We have adjuvant immunotherapy. And maybe the previous year we have adjuvant treatment for the patient with ALK mutated lung cancer. And if you see closely this picture, you can see that we have approach of perioperative treatment for the patient with lung cancer. But Professor Manegold talked about this and Professor Pilt, so this is not my topic today, but it means that we really change the situation and really change the things about the lung cancer treatment. And if you're looking the last 10 years, you see that the power of immunotherapy was proven in the clinical trials in the latest stage, in the first stage for lung cancer. I'm not sure that you see the colors of the box, but first we used checkpoint inhibitors for the fourth stage lung cancer. This is very effective treatment, so we move in the adjuvant setting, and now we try to put it and to confirm that this efficacy also works in neoadjuvant setting. So this is really changed the situation in thinking and treatment of lung cancer. And nowadays we have 4 drugs for adjuvant treatment for patients with non-small lung cancer. We have atezolizumab, we have pembrolizumab, we have TKI inhibitors, osimertinib, we have alectinib for the specific group of this patient. So we should operate this patient, decide to give chemotherapy according to the rules of the trials, confirm this efficacy, and give patient immunotherapy or TKI inhibitors, EGFR or ALK inhibitors. So this is just to summary of the trials that confirm this efficacy of the patient, and I take a very specific point for you about the ALK mutated lung cancer, because this is very interesting part of the whole picture of a patient with lung cancer. Let's see again what we have for lung cancer. We have surgery, this is for decades. So now, after the surgery, we add chemotherapy, and this improved disease-free survival according to the trials 61%, but this is less than 100 that we focused. We have specific group with EGFR mutation in the lung cancer. So after the surgery, we add chemotherapy, and disease-free survival is going 52%. But if we give a specific target drug for this patient, we improve this 2 years disease-free survival in 89. I think that this is close to 200. And for other specific group of patients without mutation, if we add after surgery chemotherapy and immunotherapy, this disease-free survival is going up till 75%. So it means that now this transformation is done. So we have to know what specific molecular diagnostics have this patient with lung cancer. So we need to know ALK, EGFR, PD-L expression in the patient on the biopsy level before staging. And when we stage the patient, we have staging of the patient, we need and we have to choose what kind of treatment we start. We can start with neoadjuvant treatment. We can choose surgery. It means that the surgery is not the main part of the treatment of lung cancer. This is a very important part of the treatment, but not main. So after this, after the results of this neoadjuvant or surgical treatment, we can choose adjuvant treatment for all these patients, because our goals now is to cure patients with lung cancer. Just to mark the trials that confirm the efficacy of this adjuvant treatment, this is Empower 010. This is 1B, 3A, non-small cell lung cancer, good performance status, PD-L expression was evaluated, and the patient received 4 cycles chemotherapy there after the operation, and they're randomized in 2 groups, atezolizumab and best supportive care, and the results of these trials confirm that it's better to give this patient immunotherapy. 75% is the percentage of the patient without disease on the 3rd year, and the overall survival also nice and close to 100%, 85% with high level of PD-L expression. This is one of the good, let's say, biomarker for efficacy of immunotherapy. So we evaluate this. The study confirmed that pembrolizumab also have good effect in adjuvant setting. They include patient with non-small lung cancer, 1B, 3A. After complete resection, they give this patient pembrolizumab or placebo, randomization 1:1. And the results of this trial confirm that the patient with the high PD-L expression, they have better PFS period of time. So this is also a nice study. And the good things come with the targeting treatment. So Adaura trial before 3 years show us that this really efficacy treatment for the patient. So this is a patient with EGFR mutation, non-small lung cancer. After complete resection, they received chemotherapy, and after this, they randomized to take osimertinib or placebo. Osimertinib gives for 3 years. And here you can see, but maybe not so clear in the picture, but I tell you that the disease-free survival on the 3rd year on the patient receive osimertinib is 85%. And overall survival in this patient in all this stage 1 to 3A, 4 years, it's 93. So I think that this is almost and very close to 100%. So the results are amazing, and we use this drug routinely in the practice, and this changed the situation with the treatment of lung cancer. One more interesting thing in this subgroup, small group of ALK-positive non-small lung cancer, this trial confirmed that because we know we use alectinib in metastatic setting, but now we confirm that this is more efficacy and best results if you give this patient in early stage. So the trial is a big one, 257 patients, but you know that this is really rare disease in lung cancer setting, and small part of the pie ALK-mutated lung cancer. So this patient included here. After resection, they was randomized directly to receive target therapy, alectinib, or 4 cycles of chemotherapy. And yes, this is the groups of the patient characteristics, but you can see that the big number, more than 50% of the patient with the stage 3A, but also included 11% of the patient with early stage, and the biggest part of the patient have N2 stage. And here it's very nice to see that the alectinib in adjuvant settings, it's have benefit for all kind of stage of lung cancer patient, and looks like that in the 1B it's maybe also more effective than the 3A. Usually in this adjuvant setting, in the first stage, it's not so clear the benefit of this patient if we give target therapy. And this is really nice picture, and it's not often seen after the according to the trials. So this is the disease-free survival, and you see the percentage 93, 88. This is for all group lung cancer ALK-mutated patients. So this is really nice results, and they are close to the 100. This is according to the new classification about the 2nd and the 3rd A stage. You see that this is consistently good results, no matter which stage, 1st or 3rd stage is the patient. The percentage is nice, 93, 84, 99, 92. So this is really close to 100. The same is in situation of about the N status. This is efficacy drug for N0, N1, and N2. You can see this nice picture confirm this good efficacy. And one more thing, I know that ALK-mutated lung cancer have previously specific metastases in the brain. So this is typical for this kind of cancer, and this is important to protect this. And you see that disease-free survival for the brain is very efficacy. 95% the patient free without metastasis on the 3rd year of adjuvant treatment. We know this drug in the metastatic settings, but here also confirmed that the toxicity is very is not big, so it's good to manage this patient even that we give drug without metastasis. So you can see the percentage of the adverse events related to withdrawal the patient of this trial. It's very small number. And I can conclude that immunotherapy and target therapy in adjuvant settings are very efficacious treatment for this patient. It means that we should discuss this patient on a real multidisciplinary board, and we should discuss what kind of treatment we give after the molecular testing. Till now, we need to know PDL, EGFR, and ALK to discuss and to decide the right treatment for this patient. So we need to test these three things. We should test for every one patient with non-small lung cancer, and we should know this information before discuss and decide what kind of treatment we give the patient. It means that not only medical oncologists, but the surgery also know about this situation to discuss with the patient. And if the patient comes first to the surgeon should discuss in front of all other colleagues which kind of treatment should be best for this patient, neoadjuvant or adjuvant after the surgery. So the situation is different. And I can say that targeting sensitive mutation in adjuvant setting, this is really good treatment and improve outcomes in the patient and improve overall survival. The patient without this mutation, immunotherapy in adjuvant setting have a good results, but maybe it's more efficacy in perioperative settings. You can see this. We should know all kind of alteration, but till now we have proven only for this mutation. So waiting for the clinical trials for other efficacy drug against specific mutation, and we want to test this alteration and abnormalities in the tumor in the best way. So we know that the good way for this is next generation sequencing, even that this is cost more financial toxicity, but this is important because we have to know the specific, if we're talking about the precise medicine, we have to know which patient have this rare mutation or not so rare mutation. And this is really good opportunity for the patient to participate in clinical trials if they have different kind of this mutation. And I can finish with this sentence that the future of oncology leads not only in the treatment, but in understanding of the genes of the disease and above all, the person behind the diagnosis. Thank you very much.